Hello everybody, welcome to my YouTube channel, Nurse at Simplified. Today we are going to discuss the most awaited topic, that is basic ECG interpretation. When we say basic, I mean only the basic. I'm not going into details about each condition, each arrhythmia, because each arrhythmia has its own way of interpretation. Do not misinterpret or do not think it is advanced. So we are only going for basic ECG interpretation. So what do you see on an ECG strip? How is it similar to what is happening inside our heart? Most of the time we miss the basic components of an ECG strip. ECG strip is nothing but it is the footprint or the blueprint of what is happening inside your electrical activity of your heart. So today we will just go through the ECG reading and its basic analysis. And as you understand the concept, in the future episodes, we will discuss each case separately. What is an ECG or EKG? It is a diagnostic tool that records the electrical activity of the heart. It is crucial for diagnosing various heart conditions, monitoring the heart health, and guiding the treatment. It is a tool, but it is not a diagnosis in itself. I repeat again, okay? It is stands for electrocardiogram. The conduction system of the heart. Why am I going to the conduction system of the heart? Is because the electrical activity of your heart revolves around the conduction system itself, my dear. So I know we have gone through it in the basic anatomy physiology during our nursing graduation, but this is basically to make you understand that each and every activity that your heart, electrical activity that your heart is performing, or whatever you see, whatever wave you see, has its relation with this activity. So as we know, it is the SA node first, that is in the atrium, followed by the AV node, which is near the periphery of your right atrium, followed by it is branching into bundle of His, and this branching it bifurcates into right and left bundle branches, and then it disseminates into the Purkinje fibers. Okay. Now, this is a little bit more advanced. Why? Because what does it mean? So, what does your P wave mean? We will discuss it in the later slides. P wave means depolarization of the atria. Let it be in your mind very clear that depolarization means nothing but very simply the contraction of the atria. Your atria is contracting after receiving the electrical impulse, okay, from the SA node. What is a QRS? When they talk, the QRS is broadened, the QRS is like this, it's like that. It just means that they are trying to find out how well is your ventricle depolarizing or how well is your ventricle contracting. What do you mean by a T wave? T wave is a relaxation or repolarization of the ventricles. The whole concept is, if you put it in a nutshell, is that with the help of an electrical impulse that is always happening inside your heart, we have the SA node which is triggered, and that leads to the depolarization of the atria, and after that leads to the responsive P wave. What is a PR interval? It is the slow delay of the AV node to allow slow filling of the ventricles. They don't want the ventricles to be suddenly be abruptly filled. It is the AV node helps to slow down or rather organize the filling of the ventricles. What is a QRS? QRS is nothing but contraction of the ventricles, and it triggers the main pumping contractions happening in the bundle of in the bundle of His and the Purkinje fibers. What is your ST? ST is the beginning of the ventricular repolarization, and it should be isoelectric. I will just show it to you with the help of a marker. It should be isoelectric. That is, it should be a straight line, a flat line generally. And what is T wave? It is nothing but it is your ventricular repolarization or relaxation. Now we come to some ECG basics. As we show in the figure already, that P wave is nothing but depolarization. QRX complex is nothing but your depolarization of the ventricles. Your T wave is nothing but the repolarization. So each component is very important. When you see any abnormality, like when they tell you, oh my God, there's no P wave. So what do you mean? It means that your SA node has not triggered depolarization of the atria. So they're confused. So these are few terms why, if for you to understand them, you must know what each wave does. When you see a P wave, it means that your heart is showing the depolarization of the atria. When you are seeing a QRS complex, it means the ventricles of your heart are depolarizing. So on. Now, this is just a small glimpse as to what it is like. Just be with me. I'm trying to play the slide for you. Just hold on. Okay, so what we can understand is that, okay, so first the SA node is triggered. I will show it to you here. The SA node is triggered. So that leads to your atria being depolarized. So it will contract, and there will be filling into the, so this AV node will open, and there'll be delayed, it will slowly try to fill the ventricles. That is your QRX complex with the help of the AV node. Okay, this is your valve. Next, we come to, this is happening simultaneously in the left atrium and in the left ventricle. That is, your left atrium is also opening. There is filling and it goes to your left ventricle. Okay, you can see in this picture. See, the SA node has triggered already. So it is trying to contract your SA node. It slowly leads to the, yes, filling of the ventricles. That is a QRX complex. So one through one, it is going from the right ventricle, it is going to the pulmonary circulation, and from the left ventricle, it is going through the aorta for your systemic circulation. Okay. Now we come to the electrode placement. We have two types of placement. One is a limb placement and one is a precordial placement. We have we place our electrodes in the four limbs. That is why it is called limb placement. Or lead wires. That is why it is called lead placement. Like your right arm, do not be bothered about the color because it changes according to your institution, what the biomedical department, what they provide with you, it changes. But generally, what we see is something like this. But do not, but be aware of your hospital machine first, equipment first. So the lead wires we have are the limb leads, which leads to your right arm, left arm, right leg. You'll be placing it on the left leg. Okay. After you place that, you have the six precordial leads, which are placed on your chest, starting from V1, V2, V3, V4, V5, and V6. How do you place them? Right RA is placed on the right forearm or wrist. LA is placed on the left forearm or wrist. LL, left lower leg proximal to ankle. Right leg, right lower leg proximal to ankle. V1, be very careful with the placement of the precordial leads. V1 should be placed in the fourth intercostal space, as you can see in the figure itself. It is here in the fourth intercostal space. 1, 2, 3, fourth intercostal space. V2 in the right side. V2 will be in the fourth intercostal space in the left sternal edge. V3 will be, but what we do generally, we place the V4 first. V4 is in a fifth intercostal space, or you can call it mid-clavicular line. Once we place the V4 in between V2 and V3, V4, sorry, we place the V3. It's easier to know that. And V5 is just a straight axillary line, it will come perpendicular down with V4, and V6 is nothing but it is just your axillary line. You can just place it below your perpendicularly down towards your axilla. Okay. Now we come to the wave interpretation. How do you interpret the wave? Why do you call it a footprint? The P wave. The P wave, it represents, as we know, the atrial depolarization or the contraction. Remember it very well. So it has a duration. It is generally a rounded picture, like a rounded body or a figure that you will see in the wave on the ECG, and its duration is 0.12 seconds. Any abnormalities in the P wave may tell you that there is some problem with the atrium, either a fibrillation or an enlargement. QRX complex. What is QRX complex? It reflects the ventricular depolarization, and it tells you how good your ventricles are, how well are they pumping. So a normal QRS duration is smaller, between 0.06 to 0.10 seconds. When your QRS complexes are wide, they show generally some ventricular hypertrophy or bundle branch block. T wave is very important as it signifies a ventricular repolarization. So if there is any difference in its symmetry means it should look the way it is, but it is looking a bit tall, or it is looking very flat, or it's looking like inverted. It means it has a problem. So it means that your ventricles are not relaxing enough for the next activity to start. So it is any change in the T wave morphology will tell you ischemia or some sort of electrolyte imbalances like hyperkalemia. A tall T wave or a peak T wave will tell you it is hyperkalemia or other cardiac conditions. Now we move on to the rhythm analysis. How do you start identifying a rhythm? This is one of the steps that I always followed when I was initially learning ECG. Ask a few questions to yourself when you see an ECG initially. Number one, heart rate. You see, how do you know that the heart rate is fine? There are many rules to see, but I will just show you the basic rule today. That is the 300 count rule. We have something called the 10-second count rule and so on. I will teach you later in the future presentations, but just for you to know the basics. Heart rate, how do you identify your heart rate? You will count the large boxes between the two R waves, and you will divide it by, you will see that you have 300 in your mind. That is why it is called 300 count rule. So 300 is divided by the large number of boxes. So if, for example, you saw between two RR there is four boxes, large boxes, so 300 divided by 4, that is 75 beats per minute. Step 2, ask, this is few questions that you will ask yourself. Ask your rhythm, is it regular? Okay, do you see that between the RR there are 10 boxes, or there are 5 boxes, or there are 6 boxes, and between each RR interval are the interval the same? Distance between the measure the RR interval. You have to measure between the QRX complexes. As you can see in the figure I have shown here, this RR interval. Next, also you will see the next RR is also the same. If they are consistent, they are regular. If they are not consistent, it means the rhythm is irregular. Next question that you will ask yourself, see the P wave now. You can see a P wave or not. Are the P waves present? First and foremost, if the P wave is not present, it has to be there's a problem with the atria, so it might be like a fibrillation. So are P waves present? Are they before every QRS complex, or is it like you have a QRS and then 2 3 P wave and then you have a QRS? So if it is so, what do you mean? It means it is a flutter. So are they all shaped the same? You have to next ask your question. Are they all shaped the same? Or you feel there is a prolong, like one of the P wave is not quite, it's not like 0.12 seconds, or it is not showing the number of boxes it should show. Next question, the PR interval. This is very important. So when you see the PR interval, as you can see in the picture, you must see this is your P and this is your R. This is your R. Okay, QRS. So this is your R. So it should be ideally 0.10 to 0.20 seconds, or to be more easy, it should be 3 to 5 small squares this time. So if it is that, it is fine. But if you see it is more, like it may be 6 or 7, it means it is a prolonged PR interval. So which means that there is possibly an AV block going on. Next is a shortened. If you see a shortened PR interval, it means some sort of pre-excitation. The SA node is having some sort of pre-excitation, which is difficult for you to, that is why it is difficult to finish that 0.10 seconds. Okay, my dear. So what is important for you to identify more than anything else? What is important for you is to see the small squares. What do you mean by WPW? It is Wolff Parkinson White syndrome. It is a very rare disorder, and if you can identify this, you can save a very important life, because it means it is a type of irregular heartbeat. It comes just before an irregular heartbeat. So it is just like an excitation, just before, maybe just before the atrial fibrillation, you can see this WPW syndrome. And it is generally due to the electrical system, like there is some sort of disturbance in the pathway, which is very rare to find, because generally patients come here with this either of atrial fibrillation or an MI. But a WPW is, you will have a short PR interval, you will have a broad QRS complex, and something called a delta wave. We will discuss about WPD later in the next videos, because it is a chapter in itself. So you will not find many patients with WPW, because it's very difficult to get such patients, because it is just before, it happens just before a cardiac electrical um, delay. Next, step 5 is ask yourself, what is a QRS duration? If it is 0.12 seconds, it is normal. 3 small squares, it's fine. If it is more than 3 small squares, maybe 4 or 5, it means there is some sort of bundle branch block going on. If it is narrow, we know narrow QRS means SVT, atrial fibrillation, atrial flutter. As you can see here, narrow. Your QRS complex is quite narrow. It is less than 3 small squares. And here is it is broader than the 3 small squares. So it means this can either be a block, BB, either an RBB or an LBB. And narrow means it can either be an SVT. What you have to see is, you have to see presence of an P wave in front to identify. Next is the very important part, what we always face challenge is the ST segment. For you to understand the ST segment, one thing very important is, I'll highlight this for you, is this J point. Can you see this J point? This is very important. 4 small boxes, if you see this J point, and if you see that this is the isoelectric line. You can see this, right? This is a normal ECG. Okay, now this is your J point, and this is a normal what do you call that, a normal isoelectric line. So if it is 4 small boxes or 4 above the isoelectric line, it is an elevation. Similarly, this is your isoelectric line, and if it is below 3 small boxes or even further, it is a depression. So all you need to know is it in the isoelectric line, and if it is above, how much above, and if it is below, how much below. Next step is analyze the T waves. It's very important to see your T wave to know whether it's an ischemia or a hyperkalemia or whatever. Ask yourself, are they upright as it should be? This is your T wave. Are they the way it should be? Or is it normal in shape, or is it like, as you can see here, any of these conditions means they are abnormal. This is your normal T wave. If you see it peaked, it is hyperkalemia. If you see it either wide or inverted, it may indicate that there is some sort of ischemia happening. Or if it is way too flattened, it may be hypokalemia. Analyze the QT interval also. The next step for you is, a normal QT interval should be 0.4 seconds, 4 seconds. A prolonged QT interval means that there is some sort of ventricular arrhythmia. Generally, a Tosadas deep point is, or this, as you can see, this is a normal QT interval for you. If it is prolonged and if it is very short, so you have to identify that the time interval, or how long it is taking for the QT interval to form. We move on to the common arrhythmias now. What are we going to see next time we see in a patient or we see a case? First, that we always want to know is about MI. Sister, how do you identify an MI? MI is, first you have to understand, and the link is already present in the chat box. I have given it in the chat box. in the description about what is an MI. For you to understand what is an MI, it's very important to know the few arteries that supply our heart, the main arteries. And when there is ischemia or there is necrosis of the myocardial tissue, how does it reflect in your ECG? So for you as a beginner, what you must see in an ECG is the J point, the isoelectric line, and how above is a J point and how below is a J point. Okay. So a myocardial infarction, what you will see on the ECG is an ST segment elevation or depression. You may see a T wave inversion or the presence of an abnormal Q wave. Next, we come to atrial fibrillation. Always remember, atrial fibrillation means something that your atria cannot do. Your SA node is not being able to capture the electrical impulse and help in the depolarization of the atria. So you will find an irregular rhythm and distinct absence of P waves. It is very important because they are a symbol that you are not doing, your heart is not being able to pump properly, and thereby there is some sort of stroke. So as you can see in the figure, this is your normal P wave, you can see, right? But can you locate a P wave here? You cannot, right? So this is an AFib. Okay. Next, what we generate a bundle branch block. Let me be very clear with you. You cannot just see a widened QRX and say that, okay, this is a bundle branch block. There are many other criteria that you have to keep in mind. You have something called like an RSR pattern. You have something called an S wave coming in. So there are many other criteria that we see in a bundle branch block. What we want you to know now as a beginner is that anything that you see that QRX is widened, is this wide. You can see this. It is wide. If you see the QRS complex is way wide than it should be, or there is a formation of an M, you can see this M here. Is it normal for you to see an M in a normal ECG? No. If you see this M formation, you doubt a QRS complex. Okay, so this helps you. So as a beginner, these are a few things that you have to ask yourself. Now it's clinical application. Always remember, interpreting your ECG interpretation involves the patient history and the clinical findings. It's not ECG. It's the patient that you have to correlate with. You have to ask her certain questions. The PQRST of the pain, the health history of the patient, the cardiac history of the patient, the history of any cardiac surgeries done before, and compare if your system has it, it's fine enough. If you can compare the ECG and the clinical condition of the patient with the previous ECG, which is available maybe a month or 2 months back. Now, how do you use them in your case studies? When you utilize your real life case studies, it helps enhance your understanding of the ECG, which means what I mean to say is you don't learn ECG by just watching a video or a short reel or anything. You learn it through experience. You see a condition in your ward or in your medical surgical floor, and you see that this patient came with, for example, MI. Let me go check her ECG. Before the procedure, what was it? After the procedure, what is it like? So you will be able to try to go back to my video, see what I told you to identify before: step 1, step 2, step 3, step 4, step 5. There were few areas that I always wanted you to identify. See how well you can identify that, and then proceed with the final conclusion. Why we always suggest that is that unless you understand the basic, you cannot understand the advanced. So just try to grasp the basic, that is, determine the heart rate, assess the rhythm, it's regular or not, identify the P wave, present or not, measure the PR interval. If it is more than 0.12 seconds or 0.20 seconds, see how well it is going. Measure the QRS duration. Is it less than 0.12 seconds? It should be less than 0.12 seconds. If it is more, it means it has a problem. Or if it is less, it has a problem. Examine the ST segment. Analyze your T waves. These are the few, like 7 or 8 questions that you must ask yourself when you see an ECG. How you integrate it with your patient history. You ask your patient history, as I always told you. Ask the PQRST first. Along when you're doing the ECG of the patient runs to you with chest pain. You are doing an ECG of the patient. Ask these PQRST simultaneously to save time. Conclusion, as I always want to tell everybody, is that don't treat the ECG, treat the patient. The patient might have lots of ECGs. His ECG might show something very weird or something very normal, but the patient does not look so. So try to treat the patient. And for example, I will just show you one very normal looking ECG, right? This is a very normal looking ECG for you. Sorry. This one. It has a very good P, it has an excellent QRS and a very good T. I'm happy. But patient has no pulse. So what could that be? I know most of you know it is a pulseless electrical activity. So what I want you to understand is the depth of the fact that treat the patient but not the ECG. But you must know the basics of ECG for you to identify early. Thank you so much. If you have any questions, please put in your chat box, in the comment box, and we can discuss it further. Do not worry. We will discuss each arrhythmia in detail, because each arrhythmia has its own different pathophysiology and way of identification in the ECG, which we cannot cover in this one chapter. So what I want you to do in this week is just take any ECG of a patient that you do and ask these 8 questions to yourself repeatedly, and let's see how it works. Thank you so much. Please continue to like and subscribe my channel, and see you in the next video very soon. Thank you. Bye bye.